Hello, my name is Dan Herron. I'm a general surgeon at Mount Sinai Hospital in New York City, and I was asked to discuss FLS, FES, and FUSE proficiency-based curricula in surgical education. Here's my disclosure. Now, the other thing I should disclose is that I am a card-carrying member of FLS, FES, and FUSE, which I think the official designation is triple F'd, something like that. But I'm not quite sure why they have me talking about surgery education in the millennial age, since I'm really a dinosaur. I'm not quite sure what age I'm from, but if you look at my FLS certificate, you can see I've got certificate number 11 from November 15th, 2004. And just to put that in context, there are currently 15,975 FLS certificates in force. So you certainly don't need any explanation of what FLS is if you've taken your board exam after 2008. Now, before 2008, the American Board of Surgery required only the qualifying exam or the written exam and the certifying exam, which is the oral exam. But there was no evaluation of any manual skills required to get board certified in the United States. As of 2008, which is 4 years after FLS was initially launched, the American Board of Surgery started requiring it as part of the board certification process. As of the 2018 graduating class, Fundamentals of Endoscopic Surgery, FES, was also added. So the current hands-on requirements for becoming board certified in the United States include not only FES and FLS, but also ACLS, Advanced Cardiac Life Support, and ATLS, Advanced Trauma Life Support. Although interestingly, none of these certifications need to be actually current at the time of certification. FLS is actually extended beyond general surgery, and as of 2020, the American Board of Obstetrics and Gynecology will be requiring FLS as part of its board certification process. So, for those of you who are not familiar, for whatever reason, with fundamentals of laparoscopic surgery, what is it all about? Well, you can go to flsprogram.org, which is the official website for the program, and find out about it. And if you do, what you'll learn is that FLS is a comprehensive, web-based education model that includes hands-on skills training and assessment tool designed to teach the physiology, fundamental knowledge, and technical skills required in basic laparoscopic surgery. So essentially, it was addressing the fact that if you go back 20 years, while general surgical principles were all well taught as part of the residency program, there was no consistent education for laparoscopic surgery, the physiologic changes involved, and the nuances of using laparoscopic tools in the field of general surgery. And FLS was designed to address these concerns. Now, interestingly, it's extended, as I mentioned before, beyond general surgery and is now considered to be an appropriate learning tool for gynecology and urology as well. FLS is not a procedure-specific tool, but rather it looks at the issues involved in laparoscopic surgery in general across different specialties. Certainly, any discussion of FLS would be incomplete without talking about some of the people who were instrumental in the development of the whole program, many of whom are well known to everyone in SAGES, Dr. Jerry Freed, Dr. Nat Soper, Dr. Lee Swanstrom, and Dr. Steve Schweitzberg. So if you're actually sitting down to take the FLS course, the first thing that you would start with would be the didactic component. This is a series of modules which are available online. They're video-based and relatively easy to sit through. 3 of the modules look at preoperative, intraoperative, and postoperative care and complications. And module 3 looks at some basic laparoscopic procedures, things like laparoscopic suturing, hemorrhage and hemostasis, how to perform a biopsy, how to do a diagnostic laparoscopy, etc. Module 5 is really what separates FLS from other educational endeavors, which is the manual skills training, which we'll get into a little bit more. Once you're done with the didactic component, you would work on the hands-on component, which doesn't really require any fancy equipment. You can see all you really need is a box trainer and some very basic tasks which are placed inside it. The 5 different tasks which you perform are peg transfer, precision cutting, ligating loop, and then intracorporeal and extracorporeal knot tying. So what do you have to do to pass the hands-on component of FLS? Well, you have to score high enough in the 5 different hands-on tasks, and proficiency level has been established by the FLS committee in terms of the amount of time that you're allowed to complete each of the tasks and the allowable errors. So for example, on peg transfer, you're allowed 48 seconds, and you have to have no drops outside the field of view. For precision cutting, you need to accomplish it in 98 seconds, and all cuts need to be between 2 circles of the training gauze, etc. for the ligating loop, the extra and the intracorporeal suturing. Now it's worth mentioning that FLS is definitely not free. There are 2 different ways that you can pay for it. If you're just interested in accessing the online didactic information, you can do that for a relatively reasonable price. It's $120 for SAGES members or $150 for non-SAGES members. And there's a little reduction for residents. They have to pay $100 just to get access to the information. However, if you are interested in the whole shebang, which is to say doing the didactics and also getting the voucher for taking the in-person test, that will require a lot more money. It's $595 for SAGES members and $755 for non-SAGES members, with a reduction down to $525 for residents in the United States and Canada. So these monetary considerations do add up, certainly when you're dealing with not just a single resident, but with all the residents in your program. Now, following the successful introduction of FLS, it became clear that there were similar deficiencies in residency education regarding flexible endoscopy, and that stimulated the emergence of the FES program, Fundamentals of Endoscopic Surgery, which is very similar to FLS, but of course focused on flexible endoscopy, primarily colonoscopy, but also upper endoscopy. The didactic component for FES is also an online program, and it includes topics starting from the technology of flexible endoscopy, preparation of patients, how to safely achieve sedation and analgesia, and then how to actually perform upper and lower GI endoscopy procedures, how to understand the anatomy, how to understand the pathology, and how to avoid complications. There is also some brief touching on the topics of ERCP, hemostasis, tissue removal, enteral access, and endoscopic therapies. In order to pass FES, you need to pass a written test with 80 questions on it, and then of course there is the hands-on component. The hands-on component is a little bit more complicated than the simple box trainer that's used in FLS because there is no simple box trainer for flexible endoscopy. So this uses a computerized endoscopic simulator, and some of the flexible endoscopy tasks which are targeted include navigation of the scope, reduction of loops in colonoscopy, targeting of tissue, mucosal evaluation, and retroflexion. Now, the most recent member of the fundamentals family is FUSE, the Fundamental Use of Safe Energy program. And this was created in order to educate residents and trained surgeons about the use of energy in surgery. Again, this was felt to be a topic which is vitally important, but is really almost taken for granted in most general surgical education programs. Now, the FUSE program is a little bit different from some of the other programs in that the didactics are available to anyone free of charge. You just have to go to fusedidactic.org. If you do want CME credit or a FUSE test voucher, you do have to pay for that. But the didactic information itself is available for free. And the format of the FUSE program is very similar to what we saw before. It's a video-based education program, again, freely available at fusedidactic.org, looking at the fundamental physics behind electrosurgery, how to prevent complications, how to use monopolar instruments, bipolar devices, RF ablation, endoscopic devices, ultrasonic energy devices, microwave devices, with special chapters focused on pediatric surgery and also integration of electrosurgery devices with other medical devices. FES is a little bit different from the FLS and the FES programs in that it is not yet a requirement for any board certification process, and also there is no hands-on component. It's also not really clear whether it ever will be a component of any board certification process, but it is, since it is freely available, it is hoped that it will become a more important component of surgical residency education. So clearly, FLS and FES are critically important if you want to become a board certified surgeon in the United States. And FES has a lot of value if you're interested in learning about the energy sources that we use every day in the operating room. But what about the literature? Does it support the value of FLS, FES, and FES in surgical education? Well, obviously that's a very big topic, and there are thousands of articles written out there about these three tools, but just to give you a sense of what's out there, we can look at some of the articles that have been written. This one looks at trends in FLS usage over the past 9 years. Does mandatory completion of a box trainer curriculum improve the apprenticeship experience? Is FLS not only for senior residents, but for junior residents as well? Do PGY specific benchmarks improve resident performance? What about for brand new interns? Does FLS help with their performance? There are also some negative studies out there as well, and this one suggests that FLS may not correlate with operative performance in a novice cohort. This looks at the differences between FLS and other evaluation metrics. And this one says there may be even some negative effects. Are there detrimental effects from proficiency-based training in FLS, an exploration of goal theory? So there is a lot of information out there, both pro and con for these, and I would encourage you to read further if you're interested. So it's clear that FES and FLS have a lot of value if you're looking to become a board certified surgeon in the United States, but do these tools have use for surgeons outside the United States? I can give you a concrete example of how I'm using FLS as a tool to help educated surgeons in Africa about laparoscopic surgery. I'm working with Dr. Joseph, who's a surgeon at the Kyabirwa Surgical Facility Center located in Uganda, just on the north coast of Lake Victoria. The Kyabirwa Surgical Center is a state-of-the-art facility that was built by the Mount Sinai Department of Surgery, but is staffed completely by local Ugandan surgeons and nurses and citizens in order to provide care to local Ugandans. You can see that it has some very interesting features, such as solar cells on the roof to provide electricity during the blackouts, which are very common in that area. And it actually collects rainwater to supply most of its water needs for its daily operations. Now, the surgeons are currently doing open surgery and flexible endoscopy procedures at Kyabirwa, but they're not yet doing laparoscopy. So this is the perfect opportunity to use FLS to help educate Dr. Joseph and his nursing staff about laparoscopic surgery and what he needs to know before we do an in-person training session. Obviously, FLS doesn't work by itself, but it's a very important component of getting this surgical center up to speed with their laparoscopic procedures. And I'm very much looking forward to going to visit in person once the COVID epidemic has come to a close. So this is a nice example of how we're using FLS in our system, and I hope it's been a valuable summary of how FES and FLS and FES can be of use in your situation. Thanks for listening.